I will be moderating the first panel discussion of the day on using data to identify gaps and solutions. This panel will highlight recent efforts to use and improve data to identify needs, disparities, and opportunities in several high-priority health areas. We will be hearing 4 presentations followed by a Q&A with our panelists. So our first panel presentation will be by Dr. Colette Adamson and Elena Seep. Dr. Adamson is Turtle Mountain, Chippewa, and serves as Director of the National Resource Center on Native Aging and Associate Director of the Center for Rural Health at the University of North Dakota. Elena Seep is a Senior Policy Specialist for the National Resource Center on Native American Aging and Project Coordinator for the Resource Center for Native Aging and Disability. Please welcome Dr. Adamson and Elena Seep.
Good morning, everyone. So today we're going to talk to you about our National Resource Center on Native American Aging's main project, which is our Identifying Our Needs, a Survey of Elders, which we've been doing for over 30 years, and just utilizing that data to help our communities, our Native communities be able to use that data to bring services and resources for their elders. Okay. Thank you. So just to start off, to give you a little bit of background of who we are. So we were established in 1994. So going on 31 years as a resource center serving tribes, Alaska Native villages, and Native Hawaiian homesteads. We're located at the University of North Dakota in the School of Medicine and Health Sciences, and we're housed at the Center for Rural Health. We're funded by the Administration for Community Living under the Older Americans Act, and we have 2 sister centers that we work with in Alaska and Hawaii. So kind of jumping right into talking about that main project that we do with conducting that Title VI needs assessment. Every 3 years, tribal Title VI programs, which are the nutrition, support services, and caregiving programs specific for our tribal elders, are required to apply for their grant funding for those services for our tribal elders in the communities. And as part of that, they're required to do a needs assessment. So that's where we come in, and we work with the tribes to conduct their needs assessment. So what happens is the tribal Title VI programs will contact us and say that they want to participate in our needs assessment survey. And so what we do is we kind of talk them through the process, and we'll ask for like an elder count, which is the number of elders that they serve or that are eligible for Title VI services in their community. From there, we'll give them a recommended sample number. And we always tell them, this is just a recommendation. If you are not able to collect that number, we will process whatever you need or whatever you're able to collect. So we kind of try to make the process fit the community rather than the community fit the process. So throughout that, then we send them their surveys to be able to conduct their needs assessment. And from there, one of the things that we do is we want this to be a true research partnership. So the programs themselves collect the data, they administer the survey. So essentially they're becoming the researcher. So they gather that data from their elders, and then they send it to us, and then we process that data, and then we send it to them in the form of a comparison sheet, which has all of their data. And then we also provide national data for comparisons. Then we do a second mail out when we wrap up the cycle, and we provide them with tribal aggregated data that they can review and kind of just compare their tribal data to that tribal aggregate and to the national data. And one thing about this is, the tribes own their own data. We don't share out their data with anyone. and what's great about this is that they have their own specific data for their communities. I guess I could share a little bit of a story. So a few of our tribes that were participating in the survey, they were working with a third party. And as part of that grant or that project, they were asked to get the data on their elders. And so that party came to me and asked if we could transfer that data to them, because the tribe said that I could transfer that data. And I said, well, it's not my data to transfer. So what I'll do is I'm going to give the tribe their raw data file back. They'll let me know who the appropriate person is, and then I'll transfer that data, and then they can decide who they want to share with that data. So we really do try to be the gatekeepers of that data for our tribal communities that we work with, because it took over 30 years to build that trust, and we don't want to lose that. And of course, we go through the proper permissions. We ask for a tribal resolution signed by their governing body. And so that provides permission for us to process that data for them. On top of that, as I've seen through the years, a lot of our tribes are saying that, under that tribal sovereignty, they have that data sovereignty. So it's good to see that a lot more tribes are developing their tribal IRBs and RRBs. So we go through that process as well. We'll fill out the application. We'll help the Title VI director work through that process and get those appropriate permissions as well. So we really want to ensure that we're improving our process and that we're getting the correct permissions and we're making this work for the community. So one thing I did want to share throughout this process, so we provide a lot of TA. And so we do this over the telephone, through email, and we even set up Zoom calls with the Title VI directors to kind of talk through any of the process. And a lot of my staff and I, when we're talking to the Title VI director, it's so great sometimes because we built some great friendships with them, because sometimes they just need somebody to talk to, talking about their program or their day or, the latest that's happened within their program. So it's really nice to, build on those relationships and just make that connection. Another thing that we've been able to do is when we go out to conferences, we always try to make it a point to visit with some of the Title VI programs that are in the area. So we'll rent a car and then we'll travel out to the different sites. And I mean, it's been so great because we've been able to meet with the elders and even have lunch with them and just kind of talk about, their program and just they have the opportunity to ask about the survey. Just last week, I was in one of our communities in North Dakota, and I got to present to the elders, and they asked questions about the survey and the data and how it's used. And in a couple of weeks, we're actually going to be talking with one of the tribes down south, and they're going to set up a Zoom meeting so we can answer the elders' questions about the survey and just kind of let them get to know us. So one thing I did forget to mention is that with the data, another way we provide the results is we provide infographics. So that way the elder is able to see the results as well. So everything goes back to the community where they can use their data to advocate or share back with their community the results and with their tribal leadership. And just to give you an idea of the participation throughout the years, so Cycle 1 started back in 1999, so you could see we had 9,513 elders participate. Fast forward to Cycle 7 and 8, we had 23,427 participate, and then for Cycle 8, which was our last cycle that ended in March 31st, 2023, we had 21,095 elders participate. And right now we're in the middle of our Cycle 9, and we have over 100 Title VI programs already working with us to gather their data. And then this is a map of our last cycle. So you could see the number of communities that participated in our survey. So Alaska had the highest participation of Indigenous communities participating with 50, followed by California with 47, and then Oklahoma with 27. One last thing I did want to mention is that for my part, then Elena's going to take over. Is that we did interview some of the Title VI directors to ask them how they've used their data and the benefits of this survey. And I'll just share a couple of things with you. One of the quotes said, "Working with elders is like being with family. You just want the best for them." Survey results help you see the disparities where the needs exist. And some of the other things that they shared with us is they don't only use the data for the Title VI grant, but they've also been able to secure grants from the CDC, the National Council on Aging. They also built partnerships in their community with IHS. They had seen that their elders had a high rate of diabetes, so they brought that data to their IHS, and together they put on an educational training for elders on diabetic foot care. Others have said that it helped them to start conversations with their elders about, do I need this routine exam? Conversations about advanced directives, medical power of attorney. So it helps spur those conversations to help provide education to elders around some of those areas on preventative health and advanced directives. They also mentioned that it helped them to let their tribal leadership see the data, so then it helped them support their efforts for their tribal elders in their communities. So this data is really important, and in our community, we do have a tribal IRB. As mentioned, I'm from Turtle Mountain Band of Chippewa, and our motto is data matters. Data makes a difference. So, and it really does, and it's empowering and impactful. And Elena's going to share with you how the data has been further used.
So, especially in a room full of people working on public health, one of the things we talk about internally is what we call like a silent crisis of public health, of serving Native elders and people with disabilities of all ages across Indian country, because there's a robust system that exists at the federal level for states that was developed around 2013 or so, called No Wrong Door, all around supporting people where they're at in their home or in their community and keeping them from nursing homes where people don't want to go. If anybody in this room is curious, there are approximately 21 to 22 tribally operated nursing homes nationwide. And they're in clusters. So there is one tribally operated nursing home to serve the entire 3-state Bemidji area. So if you're not lucky enough to get one of the 20 some odd beds at Oneida Nation, then you're going to go to a non-native facility that's quite a distance. We've mapped some of that, and on average, people were 100 to 300 miles away from home to go to some of these facilities, native or not. So there's really not this robust aging and disability network across Indian country, and nobody's talking about it enough. And so one of the things that we're doing in our newer resource center project, because we can't have enough resource centers and Colette can't have enough hats to wear, is that we're trying to build that model where tribes are able to use some of their survey data, take what they're already doing within their Title VI aging services as well as their health services, and map that up to those Medicaid waivers and that No Wrong Door program. So how we've used some of the data to drive that, you can see here, these are actual results from our most recent cycle. HDM is home delivered meals. So people who are receiving home delivered meals are more likely to be at or in danger of a nursing home level of care because they're not able to make it to a congregate meal site. We all know that this data drives the dollars and it drives the aid, and our survey has given us the ability not only to identify those elders' needs and to track them across time, but also to show that need support has remained high. Like, it has been decades running that the entire tribal population has a disability rate that is 4% higher than any other population group nationwide, and that continues to hold strong. We're still waiting to see some of the COVID effects where I expect those numbers to shoot up with long COVID, other complications that we're starting to see that are affecting elders and people with disabilities because they're the most vulnerable populations. As you know, we've been able to use this aggregate data to complete a successful application for our new resource center. And we're after another one. We're trying to nudge in on the state action in the no wrong door. So wish us luck. Because I got the 1 minute left sign. I'm coming into the home stretch. So these are some other examples of how we can use that data to actually do some other deeper analysis. So this is a peek at what we were looking at with Oklahoma specifically because they had such a large participation number, but we're in the process of doing this look at all of the states where tribes participated. We took a look at, out of all of the elders 55 and older who took the survey, we looked at who reported an income at or below the Medicaid guideline in the state of Oklahoma. And that was 7 out of 10 elders. That's a high number. They weren't enrolled, but they were absolutely eligible, which means the tribe was not capturing that all-inclusive rate for their medical services. And they're certainly not capturing anything in those waivers because these people aren't enrolled in Medicaid at all. Out of those, 79% weren't enrolled in Medicaid, which I just said, and I repeated myself because when you get the 1 minute thing, you get all nervous. And then 68% of those elders who could have been enrolled in Medicaid were already receiving home delivered meals. So what that means to us that we can tell the Oklahoma tribes is that's your target home and community-based service clients right there. So we took the overall analysis, did a deeper dive and turned it around and said, what's another lens we can look through to get you something that you can use to create and expand not only helpful programs based off of what you're already doing, but then tap into other revenue sources outside of tribal general funds in order to get that funding from the state and a federal level and show that level of need. So, see, I made it. You're like, time's up. So if you want to look at some of our programs and look at the survey, there's our link, and please come visit us. Well, thank you. You want to? Yeah, is this you? Yeah. All right.
Thank you. Thank you. Appreciate that, Dr. Adamson and Elena. Our next panel presentation will be by Joel Earlywine. Joel is a health researcher from Mathematica. Please welcome Joel.
Thank you everyone for having me here. I'm really excited about this. So I'm Joel, I'm a researcher at Mathematica. My colleague Lauren Tingy is over here. And we've partnered with the National Indian Health Board to estimate full funding for Indian Health Service. So I'm gonna go through that. So first, I wanna say, I know you are all aware of this. I am speaking to experts in the room, but I think it's important to repeat some of this as an important backdrop to this work. So the U.S. government has treaty and trust obligations to provide healthcare to American Indians and Alaskan Natives. And the Indian Health Service is the primary agency fulfilling this obligation, but it's been chronically underfunded. And this has had huge impacts on the community. We can see it with deep inequities. So this project aims to estimate the cost of providing accessible, high-quality healthcare services to meet the healthcare needs of all American Indian, Alaskan Native people. And so we are really trying to come up with the best number that we can. And we realize that doing this work, that the data that we are using, that these data are people. And so even though we're looking at it in aggregate numbers, we want to also remember the stories and the individuals that are under this data. So the primary goals of this study are to first estimate the health profile of the American Indian, Alaskan Native population. We want to understand what's really driving the need for costs so we can motivate and justify this funding number that we come up with. And so then we're going to estimate the cost of addressing healthcare, the healthcare needs of the American Indian and Alaskan Native population. The really important thing is that each of these goals build on one another. And so some of the last two goals here is providing a detailed information on really these inequities, these disparities in healthcare or in health service use and health in general, and then really to motivate this need amongst policymakers to move forward with this number to fully fund Indian Health Service. And to do this, we're going to be putting together a 4-page visual heavy brief that's very simple and is to the point for policymakers. And we're working really closely with the National Indian Health Board on how we're going to put that together. But we're also working with the Tribal Advisory Group on selecting which stories and how to tell the story to policymakers to really justify and motivate this full funding estimate. So how do we calculate costs? So we are going to be using the Health and Human Services hierarchical condition category algorithm. And so that's the HHS HCC algorithm. It predicts healthcare costs based on collecting a patient's health conditions, their diagnosis information, as well as some demographics like age, sex, and maybe the state you live in. This is this was actually based off of the CMS HCC algorithm that maybe some of you are more familiar with. It is the algorithm that Medicare and Medicaid use to distribute funds to fund Medicare and Medicaid. So this is something that they're very familiar with. And so it's speaking their language in some way. But it's also data driven. And so this, although it can predict healthcare costs, really what it's doing is it's reflecting the healthcare complexity of populations. And so, you know, for all of my data folks out here, it's a regression-based risk adjustment model. And so based on these parameters in the model, it's going to give you a relative risk based on a certain diagnosis or age group that you're in or state. And so if you have a diagnosis such as metastatic cancer, right, like that is extremely complex and costly to take care of, and that will drive up your risk score. But if you have something maybe like hypertension, it doesn't cost as much to take care of, that's a lower score. It's not going to add as much to that final risk score. And so the risk score of 1 indicates a national average. So that's the average amount of spending in the US on populations. And so anything above a 1 would indicate more health risk, but also I don't love the word risk, but it's gonna also mean that more spending is needed to take care of these groups. And so we use this algorithm to compare the American Indian and Alaskan Native healthcare costs and health need to everyone else. And so we're gonna do this using Medicaid data to start. So first, we're going to be using the 2022 TMSIS analytic file for Medicaid. We're capturing enrollees in the 19 states that have that encompass about 70% of the population, the American Indian Alaskan Native population. That doesn't mean that the enrollees that we capture represent 70% of American Indian Alaskan Natives, but the states that we're selecting have most American Indian Alaskan Natives. So to be in this sample, you need to be under 65 because we'll capture 65 and older in Medicare, as well as some IHS data if you're not in Medicare. We're focusing on full or comprehensive benefits, 12 months of continuous enrollment, and non-dual enrollment, because we'll capture dual enrollees in Medicare because Medicare is usually pays more for things and is more comprehensive. So to define American Indian Alaskan Native race in Medicaid data, we kind of took a broader approach. So enrollees with a state reported race listed as American Indian or Alaskan Native. But in addition, we capture all enrollees that have a healthcare claim at an Indian Health Service facility. And so we actually worked with IHS and received some national provider identifiers that we can identify in Medicaid if somebody had a claim at an IHS facility. And so then you would also be a part of that group. So then we have these groups, American and Alaskan Natives in each of these 19 states. And then we take everyone that's not American and Alaskan Native and we take a random sample of 5%. and those will serve as our comparison beneficiaries. So what did we find? I'm gonna describe the sample, the Medicaid sample who we're looking at. I'm also we're gonna look at that risk score. How do they score on that? The score from the algorithm. And then we're gonna look at some utilization and lastly, some conditions. And I just wanna highlight, and I might even repeat myself, but I don't want to focus on the negative, even though all of this are things you guys know. So what I want is for us to look at these data, even though we're very familiar with it, and like what is behind it? What's the story behind these data? And how can that feed into the story that we use to motivate funding? So the demographics of our Medicaid sample. So as you are probably aware, Medicaid eligibility mostly focuses on low-income families and younger people, particularly through CHIP, and also pregnant women. So I think the distribution here of enrollees is not too surprising. We have a slightly more females than males, and I think that's also due to the Medicaid eligibility covering pregnant women. And we're getting around 1.2, 1.3 million American Indian Alaskan Natives. So this is the risk score. And so this is an overall aggregated level. Here on the y-axis, you have the risk score. And then on the x-axis, you have the comparisons and then the American Indian Alaskan Natives. And so what we see here is that the comparison enrollees are at 0.99. It's pretty much the national average, exactly what Medicaid and Medicare are spending on their beneficiaries. But American Indian Alaskan Natives have a 1.25 risk score. And because of some decimals, that's 27% higher than comparison enrollees. And what this reflects is that our community here are experiencing conditions that elevate their health risk, conditions that are more costly to treat and thus require higher spending. But this does not mean that there is higher spending on this community. This is that they need higher spending, not actually reflecting actual spending. And so this is also true for all age groups and sex. So we can see here, and I have percent differences here, but you can see that it is across all age groups and across each sex. So now we're looking at utilization. Again, most of you are probably familiar that hospitalizations and ED visits are higher for American Indian and Alaskan Natives compared to comparisons. But what I want us to really focus on here, rather than just these raw numbers, are that when you look on the left, the number of inpatient stays per 1,000 enrollees, what we're seeing here is a higher level of unmet need, severity of health conditions, inadequate access to outpatient care, poorly managed chronic diseases, and gaps in preventive care. And when we look at ED visits, what we're seeing are gaps in primary care access, unmet health needs, and lack of timely access to care. And we can see that this is true as well for men and women for both hospitalizations and ED visits. So in order to make a compelling case to policymakers for more IHS funding, we need to know about select health conditions. We need to tell the story of the community and really motivate this funding. And so what we're about to see after this are the conditions that feed directly into this HCC algorithm. So what we're looking at are going to be the prevalences of conditions that are driving that difference in the risk score. And this is just one, I'm going to show you a few conditions, but these are just one of many conditions driving the differences. And we're working with the Tribal Advisory Group to select which conditions will make it into the final brief and how to tell that story. Because they have just a wealth of knowledge and they have all the on-the-ground knowledge here. So I think you guys are all aware that our communities have higher rates of alcohol and drug use disorders, as well as liver conditions. So what I want to talk about here is how all of this lack of access to treatment has this cascade and perpetuated effect. So if you take an individual, because data are individuals, who has chronic alcohol use, possibly an alcohol use disorder, and they don't have access to treatment, whether that's geographical or physical access to treatment, or it's not culturally appropriate treatment. If that goes untreated, that can lead to cirrhosis of the liver, where you have scar tissue in the liver, and it impedes its ability to work. And as you also don't get treatment for cirrhosis of liver, if you do not have access to treatment, that can lead to liver failure. So what we're seeing here is that these inequities are actually growing as the cascade effect occurs. And so this is just one of the stories that you can see, but to just always remember that these are individuals and these are their stories navigating the healthcare system. American Indians and Alaska Natives also have higher rates of diabetes. And the thing here is that diabetes care is very well established, and there are several guidelines to outline the evidence-based care. And so in order to get a diagnosis, you have to see a provider, and yet they're not getting the treatment they need. And so what we're seeing here is that these differences show limited access to affordable insulin, limited access to medications, diabetes education, and all of this can lead to complications. All right, so I haven't even talked about costs yet. We haven't really gotten there, but I will give you an example of how we use this to estimate costs. So suppose, as I showed you earlier, there's a 27% difference in scores between American Indian and Alaskan Native. If you take this table, we'll split people out by age, state, age groups, and sex, and we'll look at the per member per year cost to take care of an individual of that. And then we'll take that difference in risk score and upwards adjust the amount it takes to care, that funding amount, the PMPY. And so then, because we're only capturing those in Medicaid, we are going to actually multiply this per member per year by the total population of American Indian Alaskan Natives, because everyone should be able to access Indian Health Service. And so that is the number, is how we come to the number to fully fund Indian Health Services for healthcare costs. Now we can adjust this number for things like transportation, healthcare workforce expenses, and aging infrastructure. So I am getting the times up, and I just want to say that we will be moving on to IHS data and Medicare, doing something very simple, or similar, sorry, something very similar. Yeah, thank you. Yeah, sorry,
You're good. I just want to reiterate that that was just an example of how you're going to do the calculation. That wasn't the calculation. Yes. Yeah, just in case. But so those are quite there. So thank you, Joel. We appreciate that. I realize 15 minutes goes fast. Next up, we have a presentation from Karuna Tarumala, who is a chronic disease and cancer epidemiologist at the Northwest Tribal Epidemiology Center. Please welcome Karuna.
Hey, hi everyone. My name is Karuna. I am so thrilled and honored to be here with you today and share some of the work that we're doing at the Northwest Portland Area Indian Health Board. The Northwest Portland Area Indian Health Board is a tribally owned and operated nonprofit organization serving the 43 federally recognized tribes in Oregon, Washington, and Idaho. And for almost the past 30 years, the board has housed the Northwest Tribal Epidemiology Center, or Northwest Tech, to provide epi and public health support services to Northwest tribes. And we have heard over the past couple days about some of the incredible work being done at our sister epicenters, supporting the needs of the tribes in their areas. And though the 12 national epicenters share some core functions, the ways that we execute those core functions can vary. And we've also talked a lot about tribal data sovereignty. And in that vein, the Northwest Tech strives to provide accurate, complete, reliable, relevant, and timely data to Northwest tribes. And we've kind of defined this as high quality data And also keeping data sovereignty in mind, we are working to make sure that tribal data and the data that reflect tribal communities that may have been collected and are housed outside of the tribe are making their way back to tribal communities. So this is not considering, I'm not going to talk about like tribally collected data and data that tribes hold and all of the indigenous data that we've been talking about. But some of those kind of state held data systems, CDC held data systems, CMS, et cetera. And part of the stewardship of this high quality data at the Northwest Tech has to do with regularly bringing in those external data and cleaning up those data and making sure that they properly reflect a more complete Northwest American Indian Alaska Native population. Some of the ways that we do this is by correcting for missing and misclassified race data through record linkage, by expanding the used definition of American Indian and Alaska Native outside of just AIAN alone, in a way that better represents a Northwest tribal population, as we talked about yesterday during our census session. And by making sure that we have the newest possible data available to tribes, as Abigail touched on this morning. What's that life cycle of the data that are providing, and are they timely? But those high quality available data are not necessarily all that useful if they're not in the right hands and if they're not presented in a format that are useful to data users, in this case, tribes that are most represented in those data. And as the Northwest Tech modernizes our data services, we've also been thinking about the best ways to deliver those data, and sought input on those products from our tribal data users. And in those conversations, here are some of the words that kind of came up with tribal leaders and data users through quarterly meetings with our board. And as you can see, they kind of run the gamut and are dependent on data users' comfortability in working with data. So folks that are, we kind of over and over and again heard about having availability, like about availability of timely data, local data, specific data, but some folks just wanted raw data files to play with themselves. Others were looking for specific written text to pull out for grant applications. Some data users are really familiar with online resources and wanted kind of manipulatable data tables and dashboards. And other data users were hoping to flip through kind of physical print material. And we recognize that one or even a couple of data products cannot fit the needs of all users. So some of the ways that we're disseminating these data are, first off, through technical assistance. We've heard a lot about technical assistance. And so we know it and we love it. It's a very reliable way to get tribes as close to as possible to the data and the specific data product that they're looking for. But these requests can take time, and they also require an initiating action from the tribes, which might add an extra hurdle to that data access. And we're also working to get data out through the Northwest Tribal Data Hub. The Data Hub, so the development of the Data Hub is part of Northwest Tribal Epicenter's data modernization efforts. And the primary function of the Data Hub is to connect tribal communities directly with their data and help them care for their people and inform health policy, and inform community planning and priority development, and to help in funding proposals. The Data Hub provides Northwest tribes with secure access to their aggregated public health data, and eventually topics will include demographics and cancer and substance abuse and use, and hospitalizations, causes of death, and other health issues for tribes to view and interact with and download data through visual dashboards. And over time, the Data Hub will grow, but it is a large project that takes a good amount of time to design from the ground up with the care that it deserves, especially with that data sharing. Building a new data sharing platform like this includes things like developing a new data architecture and designing and building out those dashboards and working with new platforms to host the data in ways that we have not hosted data in the past. And developing new data sharing agreements and getting them signed, and then also making sure that we're working with our tribes consistently through the entire process to make sure that the rollout of a new data sharing platform is serving the needs of communities and is easy to work with for data users. And we still have a responsibility to continue to provide that high quality data to tribes while still developing new data sharing infrastructure. So we asked what kind of products can be developed now with our current capacity that still fill a need for data users. And that's when we come to written and published statewide health profiles or community health profiles or CHPs. And so these are broad state aggregate reports that are intended for a general audience and provide us like a small part of that data story of the health in Native communities in the Northwest by highlighting the quantitative data on health conditions. And I'm not going to pretend that publishing these reports was quick either. We started kind of planning in mid-2022 and started disseminating in October 2024. And so planning steps included identifying key partners for feedback and deciding what would go into the profiles and what would be omitted, and making sure that our team was adequately staffed. And then we moved on to analysis and making those analytic decisions, designing the reports, requesting review, and then moving on to dissemination, which we have been doing since October, and are working with kind of our tribal communities to make sure that data are getting out. So going back to kind of the planning of the community health profiles, we wanted to make sure that the contents would best help communities identify health gaps and solutions. And so we wanted to publish kind of actionable data that are easy to use. To that end, we wanted to prioritize data sources that reflect all three of our states, not just a couple of our states or some of our tribes, and reflect all of our tribes, not some of our tribes. We wanted to highlight those in-house data that have been adjusted for misclassification and missing data. And we also wanted to highlight recent data. So if data were, as we deemed, out of date, we didn't want to prioritize that in limited space. When we were designing these profiles, we wanted to make sure that they are accessible to varied levels of health data and technology literacy. So you can pick them up or access them online. And if for data users who are pretty unfamiliar with these kind of data systems, they would still be able to glean part of the story. And we also wanted to create strong visualizations. And we wanted our indicators highlighted to reflect a broad array of health domains. These are some of the health indicators that we ended up including in the community health profiles. I have left them at my table, but I have copies if anyone would like to see them. But we included data from the census, from both the decennial census and the ACS, from the CDC, from cancer data registries, and from vital stats. And the cancer registries and the vital stats were both data systems that had been linkage corrected for misclassification. Yeah. And as noted, we included information on demographics, on chronic disease, cancer, communicable disease, substance use, injury, and maternal and child health. These are some examples of some of the pages from the community health profiles. They include 1 to 2 indicators per page, varied visualizations, data callouts and interpretations, and each page also includes an image to make sure that we're centering the data being shared in community experience and reminding readers that these data aren't just data, they are representing communities. Some of the takeaways from the health profile development process were to seek feedback from fresh eyes early and often and make sure that profiles like this, they take a lot of resources to produce, and we want to make sure that like the production of them is sustainable to make sure that the data remain timely. And so to make sure that we're seeking out external input and allowing enough time for edits and making sure that decisions are logged in a centralized place so that a team putting together something like this can ensure consistency across the data product. And in kind of a broader sense, community health profiles not only provide data for communities, but can also provide a jumping off point for data users to ask more questions about their communities. And there's something to respond to instead of looking at kind of like a large, not empty sheet, but like it allows something to respond to, and it can also be used as kind of a data service menu of sorts for tribes that we work with that are not as familiar with the text data services and what is available to them. And it's also important to produce data products that cater to diverse audiences instead of putting all of your eggs in the dashboard basket. Cool, thank you.
Okay, no, yes, I did. I don't want to do that. All right. Thank you, Karuna. Lastly, we'll be hearing from Dr. Janelle Palacios, who is Salish and Kootenai from Montana's Flathead Indian Reservation. She is also the founder of Encoded for Story. Please welcome Dr. Palacios. About that, leaving you a path. Sorry.
Hello, I'm happy to be here with you all today. I am originally from the Flathead Indian Reservation. I grew up there, and because my single mother with 3 children couldn't support us, we moved to an urban area. So I also have lived in urban areas in Seattle and now in Northern California in the San Francisco Bay Area for half my life. I am also a nurse midwife, and I've been a nurse midwife for 16 years, practicing at a hospital where I do exclusive night shift work, which is kind of tough. And I teach OBGYN residents how to bring a midwife presence into the room and be with families, and also keep our C-section rate low. One of the other things that I've done is that I have been in this field, maternal child health, since I was born. My mother was a teen mother, her mother was a teen mother, and her mother was a teen mother. And in some of our communities and cultures, that was normal, that was life. But as we have gone through our historical policies that have shaped our experiences through forced boarding school experiences, sterilization in our communities, becoming a teen mother has become even more challenging and difficult. A lot of the families that I grew up with in my community and a lot of friends had children when they were young. And it's because of that experience of growing up with family members and friends, dear friends, who became pregnant at very young ages, not because they were wanton seductresses, but because of life experiences and opportunities and histories of traumatic experiences that they were forced into these experiences. I became someone who would be by their side. I've been doing community work for over 25 years, and I presented some of this work to Dawn when Dawn Warren about 20 plus years ago, where I'm trying to help people understand the intersections of our history, our ongoing lived experiences, and now that we have science that, science has confirmed the presence of epigenetic changes, I feel validated because I was talking about this 20 years ago. I'm going to talk to you about something very special and dear to my heart. I'm going to talk to you about infant mortality. Next slide, please. Oh, I got it. I got the power. Nope. This is the power. This is the wrong power. Okay, it's the big button.
The big button, there you go.
And then, where do I point? Right here.
What's working for everybody else? Why is it not working?
I'm special.
You are special. Why is it not working for her? I don't know. Can you just move it, Jeannie, please? There we go. One more. All right, maybe.
So,
We'll try. It does seem to now be working. Okay.
okay, thank you.
Do you want to go?
Yeah, no. So this work that I'm presenting on was funded by HRSA, MCHB, Maternal Child Health Bureau. And here's just a little bit about me. As a nurse midwife, 20 years experience, plus working in Native communities, both urban and tribal communities. And I was very honored to participate in a national advisory committee on infant and maternal mortality. And because I was probably the first Native person on this committee, this nationwide committee, and because we had a chair who was very open to exploring Native health, we were able to dedicate one solid year on trying to improve maternal and infant health in Indian country. And we have a recommendation list of 50 plus recommendations to address this. It's not super comprehensive, but it is a good start. And I can share that report with anyone who would like that report. You heard from my partner, Jessica, talk about the National Center for Fatality Review and Prevention, but basically all the infant and fetal deaths in our country have a clearinghouse located in Michigan. And all of the review committees for our country on infant and fetal death, they go through this clearinghouse, and the TA Center, which Jessica's a part of, and Gretchen as well, that they are there to provide TA technical assistance to the review committees throughout our country. One of the things that I have done is I have helped bring storytelling into this area for the past 4 years, helping review committees understand the importance of using storytelling to not just report numbers, but to report real lived experience. Now let's take a look at the history of racial ethnicity. This is a very condensed version, okay? So we can see from very early on that the idea for racial ethnicity was more towards just biological features, and it was really distinct of whiteness. Eventually, when we have enslaved people and American Indians, Alaska Native people, and the indigenous people of the United States were included in some of the counts, the shift kept in line with the contemporary colonizer view, colonial Western European view of pedigree and breeding, and it included blood quantum. But this was also a way to disenfranchise resources from enslaved people, and by blood quantum, from mulatto to quadroon, to think about their identity as they approximated whiteness. And then more recently, we have more sociological and social cultural interpretations of racial and ethnic identities. This is just this is taken from the US Census Bureau. If you look at how American Indians and indigenous people were classified, you can see that the term Indian first arrived, and then to prevent confusion, they added American Indian. But then around the 1950s to 1970s, Southeast Asian people were identifying as Indian. So then they had to clarify it and say American Indian, and then they would put Indian American. And now we have American Indian, Alaska Native tribal affiliation. And for many of us, we know that there is a distinct political identity tied to American Indian, Alaska Native. But for people who are not familiar with that, there are important reasons of like how we precisely talk about identity, and that whenever we are doing reports or when we're sharing presentations, we have to be very specific about the language that we use. Intersections of Native identity. This is a great visualization from Gartner and colleagues, but basically of all the indigenous people from North and South America, Central America, which is included in the US Census as indigenous, we have those that are then indigenous to the North America, right? The continental US and Alaska. And then we have those that are federally recognized, and then we have those that are state recognized. And then we have those that are not enrolled or maybe descendants, but there are these circles of identities that are happening. When someone dies as an adult, let's just say easy, we'll take an easy experience. When someone dies as an adult, who determines their identity on the death certificate? The medical examiner, Tyrone, I heard next of kin. Coroner, physician. Yeah, great. Yes, police officers, which are sometimes coroners, right? Yes. So do these people necessarily have biases? Yeah, right. Okay, so definitely there is great restraint and there's great opportunities for definitely misclassification. One of the things that I have personally learned is that my identity, when my husband and I were applying for a mortgage refinance, I listed myself as American Indian and my husband is Hispanic from Mexico. And we were under more scrutiny. We both had to provide proof that we were citizens of this country. So now I am now white when I apply on my home loan applications, and my husband is now also white because there was much more level of scrutiny for us when we identified as who we really are when we went through the home loan process, and they did not believe that we were citizens. So I also just want to point out there are situational identities, right? There are times for that. So can you imagine when it's next of kin, when it's a beloved partner who is identifying, who's being asked, what is this person, their beloved deceased, what is their identity? There may be situational times when they may not count them as American Indian or with a tribal affiliation. They may count them differently because in that particular situation. With Native identity, we know that there are lots of problems that's well documented through death and birth certificates and in cancer studies and registries. We are lucky if we are born Native American, but often we are born Hispanic and we die white as Native Americans in general. That is what happens to us. And if we look beyond single race and be more inclusive in using multiple race, then we fall out of the biracial, multiracial other category, and you can actually see our numbers pulled out from that. And then there's an issue of including Hispanic or Latino Mexican identity. You know, do we include ethnicity and how does that impact the racial identity of Native people? So these are all very important considerations. If you will, please just close your eyes for a moment and just think about being in a space. It could be where, like, as a caregiver, as an auntie and uncle, a grandparent, as a parent, as a brother, sister, but you come into a room and you find that the toddler, the 18-month-old that you were taking care of has passed away. And when you call 911 and paramedics and people come to see and to help out, and they identify that the little one has passed, the next person to come is a medical examiner. This medical examiner then sits down, you can open your eyes, sits down, and they talk with you about what the circumstances are. They're going to ask you, can you tell me how your loved one was found when you walked into the room? How did you walk into the room? Did you have coffee in your hand? Did you put it down? Did you run? Is that why there's coffee in the carpet? Can you tell me what you did? Did you turn the little one over? Did you try mouth-to-mouth CPR? They're going to ask you highly detailed questions. There was a study published in 2024 that Native babies, Native infants don't get that kind of experience on their death review. They don't get a qualified medical examiner to look at what happened when they died. They get usually a coroner who is typically a sheriff. Now imagine that same scenario, but who comes? is someone with a badge, someone with a star, and they're asking you questions. And are you oftentimes counted as a suspect when a coroner, a sheriff coroner is asking questions? You definitely are. Might you forget details? Might you withhold some information because now you realize that you're talking to the law? Definitely. So I just want you also to know that while we have underrepresented, misclassified, misreporting of Native infants in our country of deaths, and this is for all Native people, but we're going to talk about infants in particular. Native infants in particular also have a very high burden of not being properly investigated. Because when law enforcement isn't participating, they're more likely to engage with the family or the people as suspects, and the family may not share everything and divulge things. There are different ways that we can go into in statistical analysis of trying to find the missing group of Native people. You can link, we've heard that, we've heard linking with IHS data, with a different registry. You can use bridging, which is basically the statistician comes up with characters of codes and variables to kind of create what they think someone would classify to be American Indian or Hispanic or Black or white. So it's biased, okay? And then there is imputing, which is basically looking at surname, so your last name, looking at where you lived, as also another markers for trying to approximate your identity. So there's statistical analysis. We have all these funky tricks, but largely there's a lot of bias in it. When I presented to the Advisory Committee on Infant and Maternal Mortality, I shared with them that as Native people, we are the asterisk in almost every single report, and that I was trying to fight the asterisk syndrome. We are not asterisks. We are there. We are visible. You just hide us. So I was opting for the CDC and other partners to be more inclusive when they are looking at Native identities. When you're looking at other and biracial, look for American Indian as well and upcode them. When you have someone who is also Hispanic, which my children are now as well, I want them upcoded to be represented and counted as American Indian, Alaska Native as well. When we did that, they found that from 2005 to 2021, from all the child death cases reviews that they've had, that it inflated their amount of, they found about 23% more cases. And again, this is still underreported. This is not the final number. There are still more infants that we were not able to find. So we have a lot of work to do. We have to, one of the things that we can do, aside from educating the health service providers and public health providers and doctors and nurses and coroners and everyone, medical examiners and our police, but also helping the communities understand the importance of our identities and tribal communities as well, so that we are counted accurately. I just want to say that I think this is the last part, in looking at this data, one of the things that the center did was they tried to actually look for tribal affiliation. Now, in my understanding, the current U.S. Census Bureau, with tribal nations being asked to come up with all possible spellings of tribal affiliations. So whether someone is Nez Perce or they are Nimipu, and all the different ways of spelling Nimipu, which is the same, we're talking about the same people, but that the National Center for its time in 2021, they did not have that as a resource. But the U.S. Census Bureau right now for 2030 is working on that. So it'll be important. It's about educating people about tribal affiliation as well and the different variances of spelling. Because now, like people in my community, I'm Salish and Kootenai. I'm two different tribes, but the way that I would spell Kootenai, I have 4 different opportunities of spelling Kootenai or Tchuna. And there's our 3 different ways of spelling Salish. So educating the U.S. Census Bureau, like our federal partners, organizations, is a part of this work as well. I want to just shout out to the National Center and Jessica and Gretchen, who I'm here from the National Center for Fatality Review and for Prevention. When Abigail was talking about having allies and accomplices the National Center for Fatality Review and Prevention is definitely one of them. They are a part of a larger organization called MPHI, and they really are stepping up to doing internal organization work to change from the inside out of how they are engaging with communities. So that the next time there is an infant passing, that we are represented, we are documented well, that we have good relationships with the community and the family that we're trying to understand, so that real interventions can be created and meant for the prevention and thriving of these lives. Thank you.
Thank you. Wow, I loved all 4 presentations. I hope you all did too. I do have some prepared comments, but I know we have only about 15 minutes and I want to make sure we hear from our audience first. So if you have a question, please raise your hand. And again, just a reminder to use the microphone so everyone can hear, including all of our friends online. So I'll start over here with you. Me too.
Mentioned the algorithm space on us. And I know that Medicaid and Medicare underpayments, it's not the actual cost. And I'm wondering if you're addressing that though. I'm also wondering if you're thinking about and this actually connects to my question for the first person, but like I'm in compensatory care from family members, those sort of things.
Just the button. Is this working? No? Is it?
Yeah.
Yeah. Okay. Yeah. So Medicare and Medicaid definitely underpay. And so what we're doing is we're using this algorithm to look at the difference in risks, but we're not using Medicare or Medicare payments and costs. We're actually, in talking with the tribal advisory group too, American Indian Alaska Natives deserve above the gold standard. And so we're going to use a per member per year cost that is higher than Medicaid and Medicare, something like maybe commercial or something. So that is how we address that. For the other costs, we will definitely add that on top. We're working with the National Indian Health Board. They have costs that they've come up with IHS for infrastructure, new facilities, and things like that. And so those will be added on, and definitely will be consulting with the tribal advisory group on all of that.
Question? I have lots of questions, so I'm happy to ask my questions, but if nobody else wants to ask. Okay, all right, Elena, go ahead.
Oh, there I'm on a screen. So to piggyback on that question, some of that long-term care data is reported slightly differently because of managed care, where they become encounters instead of the traditional post-paid claim EHR. Is there any differentiation for that? Because right now, there's no line item appropriation for IHS for any sort of long-term care service. So Medicaid is the primary payer. And that's one of our focuses. So the minute you started talking, I was like, I have questions for that, man. So if you could talk about that just a little bit and maybe how you are or not teasing apart some of that long-term care need and its impact on those costs.
Yeah, so
I think they're all on.
they're all on.
They're all on.
So that is a great question. No,
This one's on.
this one's on? Okay. So yeah, it's a great question. When with people older than 65, we'll be capturing them in Medicare, but when it comes to long-term care, right, this is like a national crisis for everyone. And I think that that's something that we're gonna have to toggle with. Like, this is estimating care for healthcare services, and all these things have to be kind of added on at the end. And so that's something we'll be working with NIHB and the Tribal Advisory Group, but I don't have a great answer for that right now in terms of like, this is exactly what we're doing for long-term care. Please do. Please keep watching. Yes.
Yeah, over here and then, yeah, thank you.
Hi, thank you. Nanette Starr with California Consortium for Urban Indian Health. And I really wanted to hear a little bit more, and I might have just missed it, about your comparison group, because I saw a few data points where you're using a comparison group. And I know for all of us that serve Indian country, that's oftentimes a problem. It can really change what those rates are drastically. So if you can speak a little bit to that, thank you.
Yeah, so the comparison group was,
Well, sit back and talk naturally.
oh, okay.
There you go. You're good.
So
Thanks.
the comparison group is all of those who are non-American Indian Alaskan Native in each state. And so that's a very big number, right? And so there's computational issues. So we take a random 5% sample. But really what we're trying to do is compare it to the national average. And it turned out that, the comparison group, as expected, was about national average. And so that's just how we can kind of use it as a benchmark to how much more than what we're already paying in the US in terms of like for delivering care. Like take any diagnosis, right? How much does it cost to treat that diagnosis? And then if it's more complex, right? Like that's the adjustment we make, if that makes any sense. But we're not doing anything causal or modeling. And so the comparison group doesn't come into play in that way. But I do get what you're saying about like it's going to be benchmarked from them, right? But we can't just like cherry pick the healthiest group or something to make the number lower.
I guess I just want to add more of an advocacy, but that is also a really big concern, like even from the average group or when you lump everyone together. In California and with our organization, Sakui, we use benchmarks and comparison groups that are equivalent more to our communities that we serve. And so that's going to be very different than lumping together. So even if you can bring that back to whoever you're making those decisions with, because that really can make a difference on our outcomes. Thank you.
Absolutely.
So my question is about the elder assessment. When you discussed some things about your survey, my question is there an opportunity for tribes that had different questions or additional questions? Because as we're Native countries, very diverse, and it may be something very important to my tribe in the Southeast that's not.
You don't, I think it's all good.
It's all
Just-
good?
yeah.
Okay. So yeah, that's something that we, this has been a survey, like I said, that started in 99. So it's been through revisions, like with feedback from the communities. And so what I always tell the tribes is we try to make this very comprehensive, but make the survey your own. And if there are questions that you want to, additional questions you want to ask, let us know and we can process that data. So we've had tribes that actually do an add-on survey. And especially when we were hit with COVID, we were doing cycle 8. We had communities that were like, can you do these additional questions around COVID? So we did that. And we really just, like I said, we try to make our process fit the community rather than it being the other way around. So we're very open with, whatever can work for each community we work with.
Thank you, because I think one of the things that we're now recognizing is the impact of other natural disasters, and where we are Indians, we live in Indian country, and then particularly our elders and some of our housing. And so natural disasters is something we're really going to start taking more attention to. Thank you.
For sure. Thank you.
This question's for Karuna. I'm Jay Fisherman, by the way, from the state of Minnesota. In the community health profile report, the deliverables, you had listed education attainment. How granular is that section of the reporting, and who ascribes and delivers that reporting criteria so that you can publish it? Thank you.
Great question. The educational attainment section came exclusively from census data and from the ACS. And so it's not perfect. We talked a lot yesterday about ways that about census data, but those data were mostly to provide kind of community context. And again, these are statewide profiles. And so the more localized data for tribal communities, the better. Inclusion of those are kind of more to start conversations to allow tribal communities to identify places in which their stories are being served or not being served by these data, and to continue that story.
Hi, for Dr. Palacios. First, thanks for all your work on the Advisory Committee on Infant and Maternal Mortality. For those who don't know, the first field hearing in Indian country was part of the work that you did with them, so I appreciate that. We just published a manuscript on median age at death in North Dakota, and the disparity is 22 and a half years for American Indians versus non-Indians, and one of the big drivers is infant mortality. Thinking in terms of data sovereignty and stigmatization, and have you seen good examples where we can use the data appropriately and develop culturally relevant interventions to prevent infant mortality, but at the same time respecting tribal data sovereignty?
So data sovereignty or data governance, I learned from yesterday, would be different for infant mortality. It hasn't been done just yet. And it's largely has been used with adult population data, but definitely listening to Jessica share yesterday that the National Center is all for supporting tribal sovereignty in their data or data governance. Just knowing that there is a partner out there that is a clearinghouse for this information. And then it would have to be the states that are also working with tribes, because it's the states that are actually identifying the cases and bringing them to the National Center. I will say that the Healthy Native Babies project, which was a project started about over 10 years ago through NICHD, that was it was geared specifically to promote infant health and thriving, prevent infant death. And it was a toolkit, and it was rolled out in a number of Native tribal communities and an urban area as well. And the whole intention was to center education, preventing infant mortality, delivered in a culturally concordant, specific manner. And so a lot of the activities included making baby moccasins and making cradle boards. That project was then sunsetted by NICHD. And for about a good year, we did not know where it was going to land because NIH said this is not a research project. This is just a community-based project. It doesn't belong here. And it took a while, but now the CDC has revived it. They have it. And they are working right now with a few communities. With the recent changes and executive orders, a number of contracts, including my own, have been canceled that we're working on this project as well. So there is a lot to be said about what's going to happen to our infants and maternal health upcoming.
One last question.
My question is, you mentioned that by the states data is that all that data or just answer that data?
All that data from mortality records, and then also separately the cancer registry data. I have helped with some of the linkages and some of them not. Yes, yes. Happy to talk more.
Yeah.
Well, this has been a really great, all right. I have one desperate hand, the last person, last
Sorry.
question.
Hi, I'm Nicole Arthen. I'm a nurse midwife from the Navajo Nation, and I also work in Senator Ben Ray Lujan's office. So obviously lots of conversation about Medicaid cuts and its impact in Indian community. Some of the things that I see coming out of the Congress is the lack of representation of our issues as American Indian people, but also we're being left out of the Medicaid conversation, especially maternal health. As they're educating us on Medicaid and its rollouts and its cuts, the conversation around American Indians is that we're a special interest group. And so we really need to continue to talk to our Congress people that we are not a special interest group. But further, they're coming out with worksheets on the impacts of Medicaid cuts for children and elders, but of course, leaving out American Indian people. And so when we talk about data and the eraser of our communities through data, like right now, maternal health is in that place as well, because all of the conversations that I've been in with our congressional people is not including American Indian period, maternal health, and our issues and some of the challenges that we're facing in our community. And so my question to the panel is there any current data and information on specific groups within our communities like maternal health, child health? Obviously, there's a lot of emphasis on children and elders, but like our congressional people really need that right now because they're going to go to bat for our budget in the next 2 weeks. And so we really need that information from you all.
I will share this, and Nicole knows this as well personally. Just we may have the data and we may be able to share that, and definitely getting it into the hands of staffers are going to be really important. But I want you all to know that while I was on this committee, this advisory committee for our nation on infant and maternal mortality, the last administration and the first time that Trump was in office appointed 3 political appointees, which is not supposed to happen on these kinds of committees. And these appointees were trying to sway the rest of us into taking out maternal from the work that we were doing in support of infants. They were trying to help us see that the vessel was not important to the infant's health. Many of us, regardless of your background, know that the mom, the maternal, the birthing person, the pregnant person is essential to the health of the infant. So we have an obligation to continue to help educate everyone around us that you cannot separate the dyad, you cannot separate the family. And many of us would go on to say, you can't separate the community either, right? But if the first step is just recognizing that the maternal part stays in this work, the data that we have can say that we, as a developed nation, we have really poor outcomes, and we do. We are the laughingstock of many developed nations. And for one group of people, the maternal mortality rate actually improved, right? So we can frame that like white women have a 5-time chance of living versus Black and Indian women, Native American women. Oftentimes we frame it as like American Indian or Black women have like 2 to 3 times, 2 to 5 times rate of dying. But if we frame it simply that there are populations of women that live at a higher rate than we do, maybe it'll be a message that helps educate others by turning it around. Because when we do blame it, when we put it, American Indians die, right? We are also putting some sort of blame on that interpretation. But if we turn it to where there are populations in our country that thrive more so than others, maybe it will help spark interest in understanding what's going on.
And thank you for bringing this to our attention, because our note taker for NAHB right now is a person who works on maternal health. And as you may know, a National Indian Health Board I'm not part of the government relations team, but we are actively on the Hill almost daily. And so I will bring this back to, our CEO and, make sure that we can do our part as well. So I do appreciate you bringing this to our attention. Thank you.
I did want to mention,
Sure.
I mean, this isn't my wheelhouse, but my sister in North Dakota, they're doing some work, and actually she's going to provide testimony today. You mentioned Medicaid. They're working on birthing doulas where their services will be able to be billable through Medicaid. So they're trying to make some some steps forward with that in our state to get them to be billable for those services. So hopefully that goes through.
Yeah, that's great.
Yeah.
That's great.